Doctors Chen and Jeelani, Serena and Roohi, welcome back and welcome to Inside Reproductive Health.
Thanks
Thank you
for
for having
having us.
I'm glad to have both of you on here. You worked on a paper together, which I thought
me.
was interesting. It was through ASRM. It was about advocacy and it was about physician burnout. Do you want to give some context for it?
Rue, what do you think?
I was gonna say, Serena, take the lead. This is your baby. I just helped you.
We both love advocacy
Yes.
and believe in it strongly. And we, and Rue and I just like working together. So we're buds that way. She and I have done a bunch of things together. And so we're looking for excuses to work together. And ASRM, I had come to ASRM a while ago with this concept of advocacy as a solution for physician burnout because there was this wonderful op-ed piece in the New England Journal of Medicine a few years ago by a medical student about how, you know, burnout is a crisis. It's a problem we wrestle with. It doesn't just affect physicians, but obviously it also affects patients and healthcare in general. And so it's something we all have to wrestle with and need to try to find a solution. And this medical student had the insight to say, well, we could solve so many things by advocating more outside that patient physician interaction by doing things to advocate for better healthcare because in that process physicians could regain some autonomy physician and purpose and meaning in their jobs and maybe we could change healthcare a little bit and the loss of purpose and meaning in our jobs and the loss of autonomy seems to be a big part of our underlying burnout. So
I
I
want
just
I want
love
to
that
ask
concept.
about how you went down that direction further, but Dr. Jeelani, how'd you get roped into all this?
I like writing. It's no secret. I love research. I thrive on it. I think this is such a young field that there's so much more to learn about it. And why not, start becoming be the pioneer in this. And Serena and I met at a meeting and she was like, "Oh, I heard you like writing." And I was like, "I do." And then she started telling me about advocacy. And I, fortunately or unfortunately, had to be a patient before. And being in a very conservative Republican state, I saw what not having that access to care and not having a thorough understanding of how insurances play into this and how difficult it can be for a patient. When she said, "I'm working on advocacy to increase awareness and funding and insurance and all of that," I was like, "Oh my god, it sucks, like horribly to be that patient." Yeah, I want to help. And I think for a physician it could serve for me doing the, like, not necessarily at anything. Fertility is my fire, right? So whether it be research or whether it be advocating for patients, whatever it may be, and combining them all into a paper is even better. So when she said that, I was like, I want to help in any way I can.
Yeah.
So I'm understanding the passion for advocacy, but I wonder how one even comes up with the hypothesis that advocacy is at least a partial solution to burnout, because to me it seems antithetical to that. It's oh, okay, we've got a problem with burnout. Here's one more damn thing.
Yeah. That's a really interesting point. And obviously some programs to address burnout are things like let's make doctors work less, let's cut out the hours, let's get them more sleep. And certainly, we have to sleep enough. But I think it's this idea that when we're in a broken healthcare system, a lot of burnout, when you do surveys of physicians,
Yeah.
one of the top things they complain about is electronic medical records and the massive amounts of documentation they have to do, which actually takes them away from being able to see patients, takes them away from spending time with patients. And Dr. Jelani talks about this all the time on her Instagram account about that the support that patients need, that personal connection they need with their doctors, and the counseling and emotional aspect of what we do. And if we can't do that, and our patients are, getting upset and we're just spending time just clicking and clicking and clicking in front of a computer screen, that's not what we went to medical school for. And so I think that has come up time and again in multiple studies as a top cause of physician burnout. The other thing is dealing with insurance programs, as Dr. Jeelani mentioned. It's not just, she has both perspectives as a patient and a physician. So obviously the patient's upset that insurance is not covering, but here you're a doctor, you're supposed to help the patient, the right treatment, you could help her, and then your hands are tied by this faceless, nameless third party that arbitrarily decides, well, I'm sorry, we're not going to pay for the right treatment for your patient. And then the other thing is, of course, um, liability. Physicians dealing with liability. So but I always thought it's interesting, like the EMR, which combines with taking you away from your primary purpose of being a doctor, is always in all these surveys one of the top things that physicians complain about when they talk about burnout.
Go ahead, Griffin.
No, please add to that, and that because I'm going to jump on possibly a tangential point or
Okay.
at least a secondary thread.
Yeah, I was going to say, I don't think physicians get burnt, from my understanding and from what I see of it. I don't think physicians burn out by practicing medicine. I think, to put it very simply, I think it's all the logistics that come into play, and advocacy kind of helps solve these problems that may cause burnout. So to simply put it, that what you went to school for or to train for was to treat and heal. But logistically, you don't necessarily treat and heal, because then you're a businessman and you're a navigator and you're all of these other things, which necessarily might not light your fire. So bringing in advocacy, even though it feels like, holy crap, I'm adding another thing on my plate, but you're at least fighting for a cause, which will ultimately help your unresolved, not to play on words.
Yeah. And it could be really small. It could be like, instead of saying, well, I'm a doctor, I don't get involved in insurance, saying like, let me understand what the insurance challenges are, because if you're smart about insurance, maybe you can do better by your patient, and maybe it's a little extra work, but if it allows you to treat the patient better, that satisfaction you get from that it's enormous. It really is.
Well, that was the point that I wanted to jump on, which is insurance is a nightmare for both the patient and the provider, and I've seen resistance to advocacy because it's like, well, just more insurance to deal with, more patients coming through insurance, we get paid less money, it's more bureaucracy. And there's an instance that I can think of. I'm not going to say the group and I'm not going to say the state, but there was a state that was passing significant legislation that was pretty close. Resolve called me and said, can you get this group to jump in and do some advocacy, because this particular district might really push them over. And they knew that I had a relationship with this group. So I called them and they were like, yeah, we don't really want to have insurance patients. We don't really, it's not really, they didn't feel that it was in their interest. And so
I think I've seen that a lot.
Attitude, because I think I think a lot of your colleagues have that.
I think so. And I think honestly, like in way back when I first started, that's the way the field was. It was all cash field, no insurance at all. And I don't want to say how old I am, but that was definitely the prevailing attitude. But and I can understand some of it, but it's a little bit short-sighted and very narrow, because it means that you're only helping a very small segment of the population, and you're really not reaching a majority of people who actually need your help. So I think, and we used to worry about, like, if we get coverage and it's going to be worse for us. I would say our practice, sees like an enormous variety of patients, and we're able to see so many people, um, and you don't have to, you turn away a lot less people. So I've done it both ways. I've done the all cash system and I've done the insurance system, and I would say make a good money either way. And I'm getting a lot more satisfaction about serving a larger population. But there's always groups of doctors. One avenue to burnout is some doctors do step out of the insurance system and do things like concierge medicine. I think, doctors are people too. We have a huge variety of physicians, and this might not be for everybody, but, I think Rui and I both are very, we're very passionate about this. And, Griff, I know you're a big advocate also. Um, Reproductive medicine is an area where, the continuation of the human race, hugely important. Having a family, one of the most important life goals for a majority of humans. And the fact that a lot of people don't have access just doesn't make sense to me. And being able to actually make a little bit of a difference, I think, makes me feel good at the end of the day, like I'm doing what I'm supposed to do.
Okay, so your point of there's efficiencies that you can do with insurance patients. Either way, people are making good money.
Absolutely.
Their
Yeah.
livelihoods are. We can let's fiat that point and say that the livelihoods are unaffected. People might argue otherwise, but I'll grant it for here, and I'm going to continue to play devil's advocate and say, okay, Serena, I see your point, and maybe Rui, you make the counterpoint on this, but I see your point that I'm only seeing a fraction of the population, because that's what Dr. Jeelani was saying in the beginning. There's only so many people in certain states that can receive treatment, but I'm already as busy as I can be anyway. So I'm only able to help a fraction of the population anyway. We're slammed with new patients. And if anybody's listening to this, and for at least the next few months, they're probably slammed with new patients. And so I can only see a fraction of the patients anyway. Why would I add on however many more to that?
But I mean, now putting on your businessman hat, there's an opportunity for growth, right? That means if your demand is more than what you're serving, that's how you grow. So unless you're not hoping to grow in that manner, why wouldn't you? That's a good problem to have. Growth, whether it be business, medicine, whatever that reason may be why you're slammed, that's an opportunity for growth. I don't think, to be fair, I don't think we're taught business as doctors, but I really do think as doctors, you also have to be businessmen. So if you're doing something right, that you're slammed, but why not seize that opportunity, grow? Like, don't be short-sighted. If you're slammed and that's in a non-mandated state or a non-covered state, if you advocate for that, you have the potential to triple that potentially, right? Because you're only catering to that top high earning or whatever it may be, that clientele.
So I think their
Now the other
counterpoint is
thing,
we
Griffin,
can't grow even if we want to, because we don't have the capacity. We're already past capacity. So even if we wanted to meet more new patients, we could now theoretically, because there's excess demand, but we simply don't have the capacity.
So one thing, Griff, is a couple things that I think you talk about is that gaining patients, bringing in new patients has a certain cost, and maintaining patients has less of a cost. And certainly things like advocacy actually have some other benefits other than just physician burnout, but also marketing value and also employee satisfaction, which are also potentially big costs to the business owner. So employee retention, employee happiness leads to better productivity, less employee turnover. Every time you lose an employee and you have to hire a new one, that's an enormous cost. And we found in the practice that the dedication to patient advocacy, education, and awareness spills over to our employees. I for one, have found like that's a huge personal benefit to me, that it just working with a team that they're happy to be there. Like, even if they're only drawing blood or they're only collecting money, they're also feeling passionate about the mission of helping people have families. I think that that has an enormous benefit. I think that is harder to measure, but I think there's some good business data about employee satisfaction and retention being, a good investment business wise. And then obviously from a marketing perspective, I think it validates patients. It does validate your it's something to talk about for marketing, and it also, I think, helps with patient retention and satisfaction. It would be nice to be able to do some, you know more studies on that, but certainly I think that that's been a big benefit that we've seen.
So I think what you're referring to is that there is a cost for bringing in new patients. There's also challenges of new patients that can't convert, as Dr. Jeelani pointed out. One of the principal reasons that patients don't convert to treatment when they need it is financial reasons.
Yeah.
And therefore, having mandated coverage provides more people with those financial means, and so you have less of a challenge in conversion. So that could be something less of of burnout. But I think there still is a thing where everybody that I've talked to since we all got back online in May, whenever it was, is just slammed with new patients. They hardly want to talk. It's part of the reason why my firm has moved so far up channel to conversion, retention, and
Yeah.
and the other things, is because if I even say the word new patient, people tell me to go the hell away. And so the problems that we really have to use strategy and content to solve are things that have to do with operations and conversion to treatment and retention. And so what about that? I think when people think, gosh, like insurance coverage, this is just gonna bring in more people that, yeah, to Dr. Jeelani's point, I would do very well from a business perspective if I could serve them. But I don't have the nurses. I don't have the docs. I'm already slammed, and there's just no way that I'd be able to accommodate a
Yeah.
30%
I don't
more
know. I
capacity.
guess I look at it from a pure, like in some ways, a very selfish point of view is I want to feel good about like coming to work every day and doing this type of work. And it's not, obviously we've worked on legislation and things like that, but that can take years. Sometimes it's, really just like paying a little more attention to what's going on with the patient and trying to, um, take myself out of that narrow doctor role and look at them as a whole person and say, we care about these other aspects, and sometimes even just recognizing that can make a difference. And it can also be, things like just volunteer work and other things. I think that doctors should think about not just hours and money and vacations. I think we need to realize that part of our burnout is in this loss of autonomy, purpose, and meaning. And this is just one way that, for me personally, I found really to be helpful. It's not for everybody, but I think it's a concept that I think people that are burnt out, I'd like them to consider that as, one solution.
But can I say something? Because you said everyone has so many new patients, they don't want new patients. But that's exactly the point, right? Why do you think people are seeing new patients? Because everything's telehealth, access to care, so much easier, right? You're sitting at home. How quick is it to hop on a Zoom, see a patient? But what really should be key is conversion rate. How many of these news are actually seeking treatment, are actually coming into your door? And I bet conversion rate's really similar, if not lower, because of the economy and everything going on outside. People are more cognizant of where they're spending their money, how they're spending their money. It's easy to get a new patient, but the hard part is conversion. And why is it harder to convert is back to this whole advocacy thing, finances, and what that means for you. So I think it's a false satisfaction to look at your new patient volume. I think it's truly how many of those that walk in are actually getting treatment. Um, I think advocacy serves a lot of purposes, not just physician burnout. For Serena, it gives her a whole purpose of practicing medicine. But for me, it allows you to open the door to what are the limitations? Why are we not right? Why is it so? I literally did a survey on my Instagram to like 70,000 people. And I said, how many of you guys know what I actually do, like who I am? And 60% said, oh, I know what a fertility doctor does. That was like 60 something. And I was like, 40% did not know who I was, what I did. And I only did that after literally one of my patients ended up in the ER, and I was like hounding the whole hospital. Like, I can't find my patient. And finally I'm like, where's my patient? To the ER doctor. And she was like, oh, she's in surgery. I'm like, what do you mean she's in surgery? Like, no one called me. I sent her into the hospital. I have privileges. That he's like, oh yeah, I looked you up and you're a hormone doctor. I'm like, what is a hormone doctor? Like, what does a hormone doctor even do? First of all, I've never heard of that term. And I'm like, please tell me, what is a hormone doctor? But we need to advocate, because one, people not in like big cities know what a fertility doctor is, but if you still go out in the middle of nowhere, they're like, oh, like, I didn't know I could seek specialized help, and there's possible other options. Like, I think there's so much more.
And even among that 60%, how many of them really know what a reproductive and endocrinology infertility specialist
Most
is
physicians do not know.
Exactly.
Right. That's true. It's true.
This was a doctor telling me, you're just torn. I'm like, nope, double board, OBGYN and fertility. Like, it's not just, so I think advocacy serves a lot of purposes. It's information that you're spreading to not just your main niche. Your new patients don't necessarily mean you're doing good. Like, bring them in, right?
So that's a good point, really. Let's define advocacy, because Dr. Jeelani makes the point that advocacy and education are consubstantial. And so I think of advocacy as either going to or sending some sort of correspondence to a legislator or multiple legislators at different levels of local, state, and federal
very narrow
government.
definition. Yeah.
And so, so I have a narrow definition.
Yeah. I think at Roohi and I, and this brings up, because we have the opportunity here for one of our, Roohi, who has 70,000 followers on Instagram, to talk about the education and awareness aspect, because we also, I think both of us feel very strongly that part of advocacy is education and awareness, not only of patients, but also of the general public and physicians. For example, what about the millions of people who are of childbearing age who are diagnosed with cancer every year? They are all supposed to have counseling about fertility preservation. And yet all the data shows less than 50% of people actually get practical, actionable information about fertility preservation. We are not meeting the standard. And I would consider that to be advocacy. Like when Roohi does a story or an IGTV or I'm doing IG Live, and we're talking about egg freezing for cancer patients or fertility preservation for age. These are technologies that can make a difference in people's lives, and yet there's so little access to this information.
Mm-hmm. And there's so little access from their provider very often. Yes. There's plenty of information out there. How much of it is
good information, right?
And how much of it is relevant to the individual person, of course, varies greatly. And this is something that I have not been able to get as many people as I would like to see the utility of media in this way, of access, of the patients having access to them in some sort of scalable way. Because again, we've moved mostly further away from marketing to new patients, but there still is all of this opportunity to move patients through the new patient journey that you just can't do in a half-hour visit.
Right.
Because the patient is getting so much. And to the extent that you can create more content, answer more questions wildly, so that you have an educated patient who has with whom you have rapport,
connected to the
then
practice.
You can customize that 30-minute window. So
exactly.
Is that what you're referring to, Roohi, when you're is that part of the aim of your media strategy?
Yeah, exactly that. Because I think there's so many facets to advocacy, and advocacy just doesn't necessarily mean what that not to say narrow, because I think that has a negative term to it. I think that's just the beginning of it. But yeah, advocating in multiple levels. But yes.
So I try to use, we try to build systems where people can do that. There's some doctors that are just really good at doing it themselves. They do it before, whether or not their practice is involved at the practice level or not. And there was a social media panel last year at ASRM, back in the good old days when we could all get together in person still. And there was a social media panel. Both of you were on it. And Dr. Crawford made the point of the patients that come to me that are familiar with me because they've seen my content are more likely to move to treatment.
Exactly.
They're better patients because they trust me. They've been educated. I don't have any data on that though. Do you both? What's your experience with that?
I would love to have data, but I think we both have a tremendous amount of experience that it makes a huge difference.
Yeah. Patient retention is so much higher when they come in so well informed and so educated. Like I literally have, what's the common trend, right? You see a patient, you put them through treatment, they have a negative pregnancy test because not everything works, and then they go to somebody else because that is just expected. I did that. I'll be the first one to admit I switched clinics. But with this, they know what I'm doing, why I did it. So one, they come to me with a negative test with, hey, what are your thoughts on X, Y, and Z? It's more of a relationship. It's not like I'm going to get up and leave you. It's let's figure out together because I know you tried your best. I mean, the amount I can tell you of messages that I get, like, I know you're doing your best. I know it's the same no matter where I go. So I want to stay with you. I really like you. And it's this relationship, that bond you have with your patients is insane. I mean, people will come from all over because they feel that they're connected to you.
Yes. And this brings up two big pain points for you, Griffin, that you're always talking about, is, doctors don't want to do things like advocacy, and doctors don't want to do social media. And yet these are tools that can help you in your practice, that can connect you to patients in ways where you're not necessarily just sweating one patient at a time in your clinic and spend, and trying to do just one patient at a time. These kinds of activities, especially like the social media education, uh, putting a little bit of yourself out there does create relationships without necessarily just one person at a time. The patients really appreciate when we share not only our knowledge, but a little bit of personal stuff too, so that, because to show that we are human. And I think when a patient feels comfortable with you on that level, they are more likely to continue. They're more likely to feel hopeful. And I think we all know that in this age of tremendous technology where we can basically get everybody pregnant if they're open to treatment and they stick with it, the number one cause for not ending up with a baby in this field is the dropout rate.
Mm-hmm.
And I think we can address that through education, awareness, advocacy, as well as create a better experience. If the physician is happier, it rubs off on the patient too. That makes a difference for healthcare and for patients. So I think it's it's kind of a win-win-win, the whole package.
Well, we're talking about physician burnout because both of you are physicians and physicians listen to the show, but we're really talking about staff burnout as well, aren't we?
Absolutely.
To the extent that you can really advocate to the extent that Roohi's talking about and really educate people. I think this is the opportunity that we are just
And it's not just patients that we're addressing. Like my whole staff, they don't have MD degrees. They come to the IG lives, and I take selfies of them and put them on. They love that. I'm sure Roohi has the same experience. Your Vios is like, it's you can tell there's this vibe, they're happy to be there. And that makes a huge difference, not only for themselves and for Dr. Jeelani, but also for all their patients.
Yeah. 100%. And I feel like they want to educate. Not whenever my staff or the nurses see me post about something, I'll literally have them start Googling PubMed. You'll see screenshots like, oh, is this what you're talking about?
Exactly.
Oh, I had a patient walk in with that. That's so interesting. But it pushes them to learn more and be better and excel. And who doesn't want that, right? You want to surround yourself with greatness. Your patients appreciate that when they walk in. They're not walking into somebody who's like, doesn't want to be there. They're equally excited about positives, negatives, everything.
I mean, can you imagine your billing person is not the woman who just takes money from you? She's going to be like, well, I'm so glad you talked with Dr. Chen. I understand this is really tough. And yes, PGT really can make a difference. I'm going to work really hard to try to make, we're going to try to get this authorization. And, they're not giving medical advice, but the fact that they understand the language and that they consider themselves part of the team is huge. And they'll say to me, Dr. Chen, I had a long conversation. She's really sad. She about her IVF cycle, but you made a difference. And I told her she had some good questions. I told her I would ask you and I would get back to her because, like just that whole atmosphere, it makes my day so much better. And if my patients are like, oh, my billing person Kim has been so helpful and supportive, it makes for a much better experience, and that person is feeling good about her job. And so I'm that the return on investment for that is huge. Patient retention, patient conversion, employee retention, and better job satisfaction for everybody. I mean, that sounds like money in everybody's pocket, honestly.
So people in the billing department aren't necessarily going to create their own digital media accounts or have the cult followings that the two of you have and some of the doctors in the field have. But this is something that centers can be doing for their teams. And Dr. Jeelani made up the point of that she has patients that after they have a negative pregnancy test are more understanding, more ready for the next step, more prepared because of the content that she's created. Well,
yeah, because she goes online and talks about what if you have a negative pregnancy test. These are, she has those conversations.
That lesson can be applied to every single pain point in the patient journey
Absolutely.
and on your staff side. So what we've been doing for a long time, but is more lower cost than ever to do is, so we talk to the billing team, and I always try to get a video of the billing team when I can, and of a subject of just tell me why it is hard to investigate somebody's insurance coverage. Just explain the process of why it's hard. And then I want to share that with the patient before they come in. We're going to do this we're going to call your insurance company if we have to, but here's some of the things that can happen. You can think you have this coverage, but it turns out that you're actually on your spouse's plan for this, or your coworker has this, but you're not eligible.
So many challenges.
Or they waived it here, but they didn't approve it here. And if you can just show someone before they get to this problem that they're human, that there's reasons that they're going through this, that they're oh yeah, insurance sucks. I get that. In a 2-minute video or in different ways of creating the content, then you can avoid those negative reviews that people say, I got this $150 bill after I paid everything.
Griffin, you're saying exactly what Dr. Jeelani is saying. You're creating a relationship instead of this adversarial context where like, oh, I'm just taking your money. You're putting the person by your side. I'm part of your team. I'm the finance coordinator for your team. The doctor does this, the nurse does this, we're all working together to get you to where you want to go. That's your family.
Exactly what advocacy is, right? You're like advocating, you're teaching, you're educating at so many different levels. So I think by saying advocacy, people just think of that just big term, but it's not. You can do it at so many levels.
Way beyond just legislation. Yeah. Exactly.
But I think everyone's starting to do it, including you. I mean, this is amazing, right?
Yeah.
Well, and beyond the physician level, it could be applied to every single aspect of the prospect. So if any pharmacy is listening, and I know some of the fertility pharmacies are listening, I have had this killer strategy for this aspect of the nursing side that I want to work with a pharmacy on. So if you're
Well,
listening,
we
you gotta
we
call
definitely
me,
need
man,
help
because
with that.
I know how
Yeah.
to make this into something, this
Because
principle
you're
that we're
right, the
discussing for the nursing
pharmacist
side.
can be a big part of that team because navigating the medicines is a real challenge for everyone. And we should all be
So
working
hard.
together on that. But this, the reason why I want to try to adjust physicians is because I feel like physicians have a natural talent for advocacy because of all their knowledge and experience. I
And
mean,
you're all the you physicians are the bride at the wedding reception. In
we
that,
know what's
if you're at
going
the
on.
bar, everybody else is at the bar. If you're on the dance floor, everybody else is on the dance floor. If you're outside smoking a J, that's where everybody else is. And so I do think it does make sense to start with the physicians, because
And
we're
physicians
policies.
tend to have this skepticism and a little bit of discomfort when you talk about stepping out of a little bit out of your role as a physician. What I think what Roohi and I want physicians to realize is that all they've trained for makes them naturally outstanding advocates. You know, we're just like you have to have knowledge and experience and empathy and an understanding of the suffering and the barriers that patients face, and we know that, like, right here. Like, we really we live it every day, and to be able to articulate that, you're advocating for your patient.
Before we conclude, then, and help map for people how they might be able to baby step into this if they're not already, or up their game, when did you each get involved with advocacy, and how did it happen?
Me, I think being my own patient, how little lack of knowledge there is out there, how frustrating it is to sit on that side and know that there's really, you see a doctor and then it falls off. Then you talk to a nurse and then it falls off. There's really no continuity. You really have to do your own research on, like, what are the next steps? What am I supposed to be doing? And like when you go to like your primary care doctor, it's, oh, you're here for your annual, this is what we're going to do, and then you're done. But fertility, it's like it's like speed dating, right? You meet, you go, you do treatment, and if you don't speed date right, if your meet points are not good, it falls.
Yeah.
And I realized that textbook medicine, reading it, doesn't necessarily make us
Yeah.
a good practitioner. And it doesn't really teach us a lot. It teaches you pathways and organic and bio, but it doesn't really teach you human body. And that's why we're still learning and thinking of new ways to do things. And for me, that came up with, well, if I don't understand it, and I think I'm fairly smart, like decently smart, right? I'm like, I can't imagine somebody who has no clue going through this. Like, I was frustrated. I was like, what is wrong with me? Like, why am I Googling this? Like, I should know this, but I don't know it. So I think it started with that. Like, if I'm Googling it, that means other people are Googling it. And I have a science background and they probably don't. So, they can't weed out the crazy stuff. But at least I can start weeding out the crazy stuff. But I didn't, because I was like, oh, maybe McDonald's French fries will get me pregnant. I'm going to eat them. So it started with that, to be honest. And then it became way more than that, because then it became like lack of education, then culture awareness, and access to care. And it just grew. Like, it's eye-opening to see how little we've really scratched the surface and how much more we have to do.
What about you, Dr. Chen?
So as I said, like, started out in a cash pay system, and New Jersey mandate passed in 2001, and then the cycles in New Jersey exploded, and we started wrestling with all these insurance issues, but there were still so many barriers, and so I started getting really, really involved, I think, in helping a couple special patients with their insurance journey. And I was going through a lot of personal pain during this time, and just helping people, uh, just a couple patients, wrestle with their insurance authorizations and writing a couple letters and actually making a really big difference for just a few people really opened my eyes to it and inspired me to do more. And then ASRM actually had a little course on legislative advocacy. And, from there, I just started doing more and more. I really loved it. I've had an opportunity to like testify in front of Trenton, to go down to Capitol Hill, to do, to meet all kinds, legislators and healthcare staffers. And we actually have seen even our government, which we think is just totally intractable, actually make some changes, some legislative changes at both the state and federal level that are directly impacting people's lives. So I've seen it from both sides where I'm just working on one case. And now I've seen the other side where I can see policy change and I can say to a patient, hey, we just passed that law. Governor Murphy just signed it. And, this is awesome because you're going to benefit from it. So it started, honestly really small, and now and I don't spend a gazillion hours because I make use of organizations like ASRM and Resolve. So specifically, physicians in the fertility field actually have very easy ways where they can do very little but make a huge difference. And that's stuff like Advocacy Day. This year was virtual, and a physician can only talk about just the things you know about. The struggle your patients have makes a huge difference to legislators, to hear that side of it. They want to hear from patients too, but they want to hear the physician side as well. And we already have that knowledge. It's not like we're doing anything new.
As you're both talking, there's a segment of listenership that I think this is especially relevant because you know who disproportionately listens to this show? Fellows. There's so many fellows that listen to this show, and I think this is such a
Yeah.
way to fast track their career if they're not already.
Absolutely.
And
Absolutely. It raises your profile in the market. Roohi and I want everybody to join the ASRM social media special interest group, even if you've never done any social media, because our new fellows, we think we want to connect with all of you because we feel like, you have so much to offer, and social media is a big language for patients. They want to hear from you,
I mean, Rui, you went from being a brand new doc that wasn't busy because you were just brand new to being really busy, really fast. And I think that I think that that's replicable for
Yeah.
a lot of other docs.
But I don't want people to be intimidated. Not everybody has to have 70,000 followers like Roohi, and you can still benefit from being on there. I mean, Roohi's like obviously, one of the top people in our field. But just doing that, following Roohi on Instagram, hopefully follow me too, because the stuff we talk about, I think, will be helpful to the new fellows coming out. We hope that they connect with us. We want to hear from them.
And it totally doesn't matter how many people you have. It's your quality of your followers. I got an Instagram where it was really easy to grow, right? 4 years ago, you could grow very rapidly. It was very new. Since then, Facebook
People should have read my article, Why Fertility Doctors Need to Be on Instagram in 2016. Because guess what? That ship has sailed. It's not as easy anymore.
No, it's definitely not easy. You can see like people are starting to plateau. And it doesn't matter how many followers you have. It's just the quality. It's the quality of the relationship you build with your current patients, who then send you more patients. And I mean, if you want your practice to grow, it will grow.
And I keep going back to this, but I think I think it's just fun and a tremendous amount of personal satisfaction, right? Like this is Griffin, you and I are Twitter buddies, right? That's how we first met, was on Twitter. You reached out to me, and, I consider you a very dear friend now. And the same with Roohi. We met through social media first. It was a great way for us to connect. We already knew that we were kind of on the same page and passionate about the same things. And then when we're in person,
you wrote the foreword for my book. Like that's a form
we have
of
such
advocacy.
an amazing time.
The first time we ever met in person was in Washington, D.C. at a legislative
exactly
event. So it just expands your network in the field exponentially.
Yeah, personally, it just has brought me so much, satisfaction and happiness. Like knowing you two, like you guys make me so happy. I feel
Aw,
like a big
shucks.
privilege
I know,
knowing
but you
both of
guys
you.
make me happy. I feel
Likewise.
like a celebrity being on Griffin's show.
Well, you are. Everybody on Griffin's show is, he's making
Yeah.
everybody famous.
I'm thrilled to have you both here. It's been a pleasure. I look forward to having both of you back on, and I'm hoping that you get some good comments about today's episode. Doctors Serena Chen and Roohi Jeelani, thank you so much for coming on Inside Reproductive Health.
Thank you for having us.
Thanks, Griffin.